Hello guys. So today we'll be taking a small topic from the sclera because all the time I receive so many doubts that which staphyloma will be found where, and I don't want you to mug up the things. So let's see today that what do you mean by staphylomas, what are the different kind of staphylomas, and therefore which type of staphyloma will be found at a particular place. So let's get started. First of all, what is actually a staphyloma? What do you mean by staphyloma? So this word staphyloma comes from the word staphylos. It has come from the word staphylos, and the meaning of this word staphylos is the bunch of grapes appearance, the bunch of grapes. So staphylomas is the word which is literally defining the appearance of the organ. Now what do you mean by that? The localized bulging, or there is thinning. Whenever there is thinning in the outer tunic of the eyeball, or whenever there is a weakening in the outer tunic of the eyeball. Now what is the outer tunic of the eyeball? It is actually the fibrous coat. The outer tunic of the eyeball is the fibrous coat, and we know that this fibrous coat can be divided into anterior 1/6 and posterior 5/6. Anterior 1/6 will be the cornea and the posterior 5/6 will be the sclera. So whenever there is thinning, there is weakening in this outermost tunic, outermost coat, outermost layer of the eyeball, be it the anterior 1/6, that is cornea, or be it the posterior 5/6, that is the sclera, that is leading to the bulging of the eyeball. So suppose you have this eyeball, okay, and this is your outer coat of the eyeball. So this is your fibrous coat. So if I am getting the thinning and weakening of this cornea, so cornea will be bulging out, something like this. Then this is a staphyloma. Similarly, if I have a degeneration in the sclera and the posteriorly sclera is bulging out, then this is also a staphyloma. Now what are the consequences? We know that this outer coat of the eyeball is lined by what? It is lined by the uveal tissue. Do you remember we always draw the three coats? The outermost we are drawing always with the black color. Then I draw it with the red color, that is representing your uveal tissue. And then we draw with the blue color, that is your inner coat, that is your nervous tissue. Yes or no? So what is happening if there is thinning and ectasia of this fibrous coat of the eyeball, the tissue which is lined, that is your uveal tissue, it starts shining through it, and that is why when we have got so much of thinning of the sclera, we also get the blue sclera. So we will be talking about that also, that why blue sclera is obtained, where do we get the blue sclera, and why is it occurring. Alright. So now coming to the classification of these staphylomas. So broadly speaking, these staphylomas can be divided into 5 categories. We have anterior staphyloma, then we have posterior staphyloma, then we have equatorial staphyloma. Now can you see I am changing the order because this order is easy to remember. If you go with reference to the equator, see this is your eyeball, okay. So what is the geographical landmarks? Anteriorly we have anterior pole of the eyeball, posterior pole of the eyeball, okay, and then in the center you will be having the equator. So these three things are very, very easy to remember. So anterior ectasia will be anterior staphyloma, posterior ectasia will be posterior staphyloma, and passing through the equator is your equatorial staphyloma. Is this very, very clear? Now you have two more. We have intercalary staphyloma and ciliary. So this ciliary is also self-explanatory. If you are having the ectasia at that place which is actually lined by the ciliary body, so if you are getting at that place, that will be called as ciliary. Well, what do you mean by intercalary? So this is something related to the iris, or I can say the root of the iris. So we'll first see one by one and then we will compare. Okay, so first see the anterior staphyloma. You already know what do you mean by staphyloma, that is your bunch of grape appearance. So if I am having this staphyloma, this ectasia of the eyeball anterior to the equator, that will be called as anterior staphyloma. Now obviously when it is anterior, it has something to do with the cornea, because cornea is the anterior 1/6 of your outer tunic of the eyeball. So what is that one thing that can cause the anterior staphyloma? It can be perforating corneal ulcers and the injury. How? Now let's see, this is an important thing, how it can take place. Suppose, imagine this is your cornea. Okay, we are seeing the section here, and here we have the iris, right? Then I have the ciliary body, and this is your lens. So we are making up to this. Now you know this ciliary region will show you the ciliary processes, something like this, and through the ciliary processes we have the ciliary zonules holding the lens in its place. So this is again very, very clear, and you can then we can draw the layers of the cornea. We have the different layers of the cornea. Now when I am saying that the corneal perforation has taken place, what is the meaning of this? When does the perforation take place? See, it's a very small thing, but you should know the pathology of the corneal ulcers, then it will be very easy for you to understand this anterior staphyloma. Whenever you have the corneal ulcer, now before this you should also know that which kind of corneal ulcer I am talking about. So it is mainly the bacterial corneal ulcer. What we are talking about is mainly the bacterial corneal ulcer, because which of the keratitis is actually notorious for causing perforation? It is actually the bacterial one. Now why is it so? Because whenever this starts, it starts from the superficial layers. And what is the first thing that takes place? The first thing is your epithelial erosion. It always starts from the epithelial erosion, and then we have the secondary bacterial infection taking place. Right? Now when the infection starts, what is the first response that is taking place? The first thing is the polymorphonuclear infiltration. Polymorphonuclear infiltration, and lot of cells will be accumulated, and this will actually lead to the active ulceration. Yes? Now what is happening, because it is a polymorphonuclear infiltration, that is your inflammatory cells, so I'll be representing them with the red color. So it is starting from the epithelium, slowly and gradually it is going to the deeper layers, it is going to the Bowman's membrane, then it is going to the stroma. And you know that this stroma is accounting for more than 90% thickness of the cornea. So once it has crossed this stroma, the chances of perforation becomes very, very high. Now next what you are getting is your pre-Descemet's membrane and your Descemet's membrane. Okay, now this is a very thin layer, newly discovered, 16 micron. So here we are concerned about this Descemet's membrane. This Descemet's membrane has that property that it can actually stop the impending perforation. Why? How it can take place? Due to the formation of the descemetocele. Due to the formation of the descemetocele. Cele means cavity, herniating. So this layer can be herniating here. It can be stopping the perforation. But if it is going beyond the Descemet's membrane also, and Descemet's membrane also becomes weak. Maybe the organism is much virulent, or maybe the host factors are having less ocular defense mechanism. So whatever may be the reason, there may be some precipitating factors, aggravating factors, stress can be there, there can be constipation, there can be lifting heavy weights, anything that increase the pressure. So that can lead to frank perforation. So what is happening now? We have got a lot of accumulation of these inflammatory cells inside also, because there is a lot of inflammation due to this ulcer. It's going deep here. So we are having even the iridocyclitis. So I am showing these organs also with the red, because we have a lot of inflammation, and obviously these inflammatory cells have gathered here. Now suddenly there is perforation. So what will happen now? When there is perforation now, there will be no cornea. Can you see? This cornea will be removed now. So we do not have the cornea, but we have the iris here. We had the ciliary body. We had the lens here. So what is happening? Whole of the aqueous humor is now coming out, and this was actually filled with the inflammatory cells. So what is happening now? These inflammatory cells are gathered over the iris. This iris tissue also prolapses out. It is also coming like this. Why? Because you have aqueous humor behind this also. So when perforation is taking place, what is happening? There is a sudden gush of aqueous humor that will actually bring this iris also, and over this iris is the accumulation of these inflammatory cells. These are your inflammatory cells which are getting in place here, and they are forming a kind of the pseudo cornea. So this is not cornea, because cornea has gone into perforation, but a pseudo cornea kind of a thing is formed here. Now whenever we have inflammatory cells, and ocular defense mechanism is also working fine, what is the next step that will take? So there will be fibrosis. So there will be fibrosis, and we'll be drawing fibrosis with this orange color. So there is fibrosis here, and fibrotic tissue, they are organizing over the inflammatory cells, something like this. So this fibrotic tissue, which is now organizing, and this is also forming a layer over the iris. So this forms your pseudocornea or the false cornea. So this is also forming a false cornea. Now the word pseudocornea and the false cornea, as I told you before also, they can be used interchangeably, not a problem. So what is happening now? The pressure is building, because there are more and more inflammatory cells present inside the aqueous humor. So what is going to take place? This all is pushing this material anteriorly like this. So what is happening now? We have got the iris here. Suppose this is your iris, and over the iris now everything we have ectatic. So we have got this inflammatory cells, and then we have got what you called as lot of fibrotic tissue that is also bulged out. So this appearance that you are getting, bulging out appearance anteriorly, the bunch of grapes appearance, something like this anteriorly, this is called as anterior staphyloma. So you are going to get this in cases of corneal ulcers, the perforating corneal ulcers, and obviously the perforation will be large perforation, because you know, if you have just a small perforation, suppose it is something like this, just a small perforation, then what will happen? Small amount of iris tissue will come and it will actually seal this area like this. So what will happen now? This small area which has been sealed by the iris, this will be called as the adherent leukoma. Then this will be called as the adherent leukoma and not the staphyloma. So this is the basic difference in the pathogenesis. When do you get the iris prolapse? When do you get the adherent leukoma? And when do you get the anterior staphyloma? Why do you call it as leukoma? Now that is also important. Why do you call it as leukoma? Leuco means white. So you are getting the opacity. Oma means opacity. So you are getting a whitish opacity over the cornea due to the adherence of the iris sealing the perforation by the iris. That is why it is called as adherent leukoma. So I think now it's very, very clear what do you mean by anterior staphyloma. Now next we come to intercalary staphyloma. Now do you get something? The name is intercalary. So means there is some area where we have like demarcation. So we have the fibrous coat. Where do you get that demarcation? Demarcation is at the border of cornea and the sclera. So where you are having the adjacent areas, there you have the junction is the area which is your intercalary. And what is that junction called as? That junction is called as the limbus. And this limbus is marked by what area? This limbus is marked by the root of the iris. So if I have something which is just making the outer tunic of the eyeball weak at the place of the corneoscleral junction. Corneoscleral junction, that is your limbus. That is your limbus. That limbus which is actually lined by the root of the iris, then that staphyloma will be called as intercalary staphyloma. Is this very, very clear? Now, when do you get this? When you can get this? Whenever we have marked corneal astigmatism. Now what is happening? Suppose there is lot of stretching of the cornea. Now that can be due to birth also, congenitally may be present. Then it can be due to surgeries, and that is why it is said that whenever you are doing the surgery, maybe cataract or any other thing, the suturing has to be done very, very perfectly, because you know what can happen if the suturing is not that perfect, the patient may be having improvement of vision due to the extraction of the lens, but the astigmatism may even worsen that case. So that is very, very important. So what is happening if you have stretching, or you know, when we give the limbal incisions, where do we give the limbal incisions? Limbal incisions are given in the cases of the cataract surgery, and then we are putting out the sutures. So we are putting the interrupted radial sutures, 5 or 6 sutures or maybe more are applied according to the size of the incision that you are giving. So that can lead to the astigmatism, and obviously astigmatism will lead to the defective vision. So I can ask you that which kind of staphyloma can cause astigmatism? So it is your intercalary staphyloma. Okay, then there can be, because you know that is the root of the iris. Now because it is occurring at the level of the root of the iris, and this root of the iris is one of the structures in the angle of the anterior chamber. Yes or no? What are the structures of angle of anterior chamber? First is your root of the iris. So it is actually starting from here. Then we have ciliary body band. Then we have the scleral spur. Then we have the trabecular meshwork. And finally we have the shawl base line. So obviously, because the root of the iris is one of the structures in the angle of anterior chamber, it can cause your secondary angle closure glaucoma that can also take place. So what we are going to do, what we can do for the treatment. So for the treatment, I can do the staphylectomy with the steroids. So wherever I am getting that ectasia, and due to the ectasia, due to the uneven surface of the cornea, I will get the astigmatism, I can get the glaucoma, so I can cut up that part. And also for the healing, what I am going to do, healing means for the cessation of the inflammation, so that in order to combat the inflammatory part, I can give the steroids. Okay. Next we come to the ciliary staphyloma. So this is self-explanatory. This ciliary staphyloma consists of a bulge where we have the ciliary body. So if the bulge is taking place in the sclera at that part which is lined by the ciliary body, I will say that this is a ciliary staphyloma. And exactly speaking, where I am getting this is your 2 to 3 mm away from the limbus. Now this is again an important clue. Suppose you are getting a question on staphylomas, okay, and they are saying that the bulge is 2 to 3 mm from the limbus, then you will clearly get to know that this is not the intercalary. Intercalary will be at the level of the limbus, while 2 to 3 mm from the limbus will be your ciliary staphyloma. Okay, now a very important aspect where they can ask the question. So where do you get the ciliary staphyloma? So do you remember that when we have the perforating injury and we have this sympathetic ophthalmitis? In cases of the sympathetic ophthalmitis, the trauma is actually taking place at the level of the ciliary body, that is called as a dangerous area of the eyeball. So in cases of the perforating injury, we will have the ciliary staphyloma. Then second important thing is the scleritis. Now, in the video where I was discussing the scleritis, I did told you there that it is actually the ciliary staphyloma that I am getting in the scleritis. And the third important thing is absolute glaucoma. Why I am getting ciliary staphyloma in the absolute glaucoma? Because in the absolute glaucoma, what is happening? It is the ciliary body which is getting affected. You know, in the last, when there is lot of pain, but the eye becomes blind, we have painful blind eye in cases of the absolute glaucoma. So ultimately what we have to do, we have to actually destroy that ciliary epithelium so that aqueous humor stops forming. So in that matter, the absolute glaucoma can show the ciliary staphyloma when you are manipulating it at the level of ciliary body. Then next we come to the equatorial staphyloma. So here what is happening, we are having the staphyloma in the equatorial region. So in the equatorial region, what we are having, the area which is lined by the choroid. So it is the bulge of the outer tunic, posterior side as well as equatorial side, it will be the bulge of the sclera. Only in the anterior side I will have the bulge of the cornea. So I have the bulge of the sclera. Can you see? Now I have three parts. It is the bulge of the sclera, number one. It is lined by the choroid, number two, and in the equatorial region. This is called as the equatorial staphyloma. Now at the regions, mainly where it is taking place where it is perforated by the vortex veins. Obviously, if there is certain thing which is bulging out, it will bulge out when it is thin, when it is weak. So why it is getting weak there? Because of the perforation by the vortex veins. How many vortex veins do we have? We have 4 vortex veins: supronasal, infranasal, supratemporal and infratemporal. So what are the reasons where I can get this equatorial diameter? So one is scleritis, staphyloma. So this is next important, second most important. The most important was the ciliary staphyloma that you get in the patients of scleritis, and in the next we have got this equatorial staphyloma, and then we have the pathological myopia. Now this is again second most important, because the most common that you are getting in pathological myopia is P for P, that is your posterior staphyloma. So always remember, equatorial staphyloma is not the first choice, it is the second one in both the cases. Now we come to the posterior staphyloma, because out of all these staphylomas, most important clinically I would say is your anterior staphyloma and the posterior staphyloma, which are clear cut. That is corneal staphyloma and that is scleral staphyloma. So what is happening here? It is the bulge of the again sclera lined by the choroid. And what are the common causes? Now that is the most important point. We have pathological myopia, posterior scleritis, and the perforating injury is one of the most important question. So what is happening? In the pathological myopia, what happens? If you remember what is happening, suppose this is your eyeball. So in the pathological myopia, we have actually the bulging of the eyeball outside the biological limit. It is overextension, overbulging. So when there is overbulging, there will be degeneration of the sclera also. There will be degeneration of this choroid, as well as there will be degeneration of the retina also. So all three layers are showing overstretching. And what is happening therefore? Therefore, when you see there, you see lot of vessels are seen. Why? Because retina, there is overstretching, so you are seeing lot of choriocapillaries. That is why you get what you called as tessellated fundus. That is called as tessellated fundus, or it is also called as tigroid fundus, tessellated fundus or the tigroid fundus. We get over due to the stretching what you called as myopic crescent. Yes or no? And then what do you get? You get the stretching of the sclera. It bulges out because of the overstretching. So it is becoming something like this. So this posterior ectasia, this posterior ectasia of the sclera is called as the posterior staphyloma. This is called as posterior staphyloma. So that is the reason why do we get the posterior staphyloma in the pathological myopia. Posterior scleritis. Obviously, if I am already having the scleritis in the posterior aspect, then I will have the posterior staphyloma. Now, most common staphyloma that you are getting in scleritis is the anterior staphyloma. Why? Because the scleritis most common, 98% is your anterior staphyloma. staphyloma. Only 2% people shows the posterior staphyloma. So obviously when it comes to the staphyloma, the scleritis will more commonly show the anterior staphyloma. Now diagnosis can be made by the ophthalmoscopy. You can see it, you will see that area is excavated, you can see the retinal vessels dipping like it. Like do you remember in cases of the optic disc cupping, glaucoma? So there also, when what happens, if you imagine this is your optic disc and we have a cup here, so because the cup becomes so deep, so there also the vessels appear as if they are dipping inside the cup like this. So say similarly we are getting here also. Okay, now something about the blue sclera. So as I told you that what is happening, we have got the thinning of the sclera and it is actually lined by the uveal tissue. So there is some appearance of bluish area through the sclera. That is why, because of the bluish appearance of the sclera, it is actually called as the blue sclera. So if you look here, can you see this person is very prominently showing you something, and what is that? This is the bluish appearance of the sclera, and this is actually called as blue sclera. So there is no pigmentation here as such, or there is no collection of the blood or something. It is just the appearance of the inner uveal tissue that you are able to see now, because the sclera has been thinned out or it has been stretched out. So that is an important thing. Second important thing is that it is a asymptomatic condition. So the person will not show you any symptoms here, but it is the sign or the appearance that is important. There is a generalized discoloration that is occurring due to the thinning. Now two other important things are that what is the most common cause? Most common cause, and what is actually the DD, because you may get the questions related to the differential. If you are getting a person with the blue sclera, then what will you think? What will be the approach of this patient, how to solve that question? So first of all, remember that there are two basic reasons when I can get this bluish appearance of the sclera. One is that you are having the thinning, right? Now this thinning can be due to two things. One is the defective development of the connective tissue, and that is why because of the defective development it is thinned out. Second is that it is not defective development, rather it is some pathology, myopia, or there can be perforated corneal ulcers or scleritis or glaucoma, anything due to which there is secondary stretching of the sclera, and that is why we are getting the blue sclera. So what is the most common cause? So if I talk about the most common cause, then it is osteogenesis imperfecta. That is the most common cause. So that is a defective development of the connective tissue. If you look at the word itself, it is saying that it is osteogenesis imperfecta. Imperfect development of the tissue is taking place. That is the most common cause. Now what are the other disorders of the connective tissue? That is why we can get it in the Marfan syndrome also, Ehlers-Danlos syndrome also, pseudoxanthoma elasticum we are having. Now pseudoxanthoma elasticum is again important because here we also have the angioid streaks. See, this is a very good way of learning. Whenever you get something where any other thing is also prominent, and rather it is the most common cause of the angioid streaks, then you should remember it that time also, so that when do you get this same thing in the question in the exams also, that will certainly strike you. Now if you look at these three causes, the other three causes, now they are important because they are not related to the connective tissue, they are related to some of the pathology. So this may be giving you an integrated question, maybe the question is something else, but it is also mentioning the blue sclera, and sometimes what happens, you do not know entire thing about that scenario, but one thing you know, that blue sclera occurs there. So even that little thing will help you solving that question. See, don't always wait that you should know everything to solve the MCQ. That will never be happening. So to be very honest, because it's not possible to know everything about all the 19 subjects, and that is not even required. See, you don't have to become the encyclopedia of the 19 subjects. You have to gain enough knowledge and enough skill to solve maximum questions related to the 19 subjects. You become encyclopedia of only that subject which you will marry. I mean, you will do the PG. Yes. So how to solve those? So if you think about the Ophthalmos now. Ophthalmos, that is your congenital glaucoma. So if I am talking of a baby who is having BPL card, the blepharospasm, the photophobia, the lacrimation, corneal edema, there are so many things, and then I say that there is some bluish appearance of the sclera, or maybe they have given you the image. Image based questions are very, very common here in Ophthalmos. I've even showed you those images many times that like AIMS people have asked 2 times the questions on that blue baby. So that bluish appearance of the sclera at that time will help you solving that question, and the answer will be right in front of you. That will be Ophthalmos. Similarly, if I am giving you a patient who is having a high myopia, -9, -8, -7, and then we say that there is a tessellated fundus or myopic crescent, then again this blue sclera will again help as a prompting feature that yes, it can be a case of pathological myopia. So obviously they won't say just by the blue sclera only that you have to make the final diagnosis. That is only a DD. But the age of the patient, the related symptom of the patient, the refractive status of the patient, the IOP or the slit lamp pathology, whatever are the other things that they have given you, along with that they will certainly help you in approaching the question. Similarly is your heel scleritis, because the 98% of the times we have anterior scleritis, non-necrotizing, diffuse, so we have the anterior staphyloma, but 2% of the cases can be having posterior scleritis, and therefore that time we can have the posterior staphyloma. So I hope you got to learn certain important things. Now what happens, in the class we have a limited time and we have to focus on the high yield topics there. But when you feel like that you have read enough, we are doing daily discussions, and now we can afford some little time on the other topics also. So this is a small attempt to help you to get that extra edge. Okay, main is your notes, stick to your notes, but once you have finished with the notes and you have that thirst of learning extra to get that extra edge, and you have that dream branch or dream seat in the central institutes, so this is an attempt to help you in that. So in case of any query, any feedback, any suggestions, I always welcome you. You people can ping me up at any of the social media platforms. You can find me on my Facebook group. You can also visit my Facebook page. I am there on Insta, Dr. Niha Aggarwal there, and follow me on my Telegram group and Telegram channels. I am doing daily quizzes in order to help you, to keep you acquainted with the ophthalmology, because I know it's a volatile subject. So no matter how much ophthalmology if you leave that subject, after some time you will feel that you know nothing. So that is not your problem. That is a basic thing. Even the easy subjects which are not that volatile, you tend to forget them also. And ophthalmology is a volatile subject, I must say. And though people get to say that it's a short subject, I will say it's not a short subject. It's not a large subject even. That is the beauty of ophthalmology. It's a complete package in itself. So it comes somewhere in the middle variety, and it's a volatile. So it's a good idea that you keep on revising some small topics daily, so that you do not get this feeling that you are not remembering anything. So keep on revising, keep working hard. See you, and happy ophthalmology.